IF as filer of clinical pregnancy after 4 good quality embryo transfer with at least 3 fresh or frozen IVF cycle and in women under the age of 40. Copeland suggests a more complete working definition taking into account maternal age, number of embryo transfer, and number of cycles completed. It was mentioned about the embryo and the endometrium can both play an active role in recurrent implantation failure. How about the incidence? The incidence of IF in the world in 2006 is about 10% of cycle, depending on the definition. IF can impact to the couple, make the patient distressed, to the doctor. It makes the increase on the cost of IVF, impact on management, and IF still major challenge to the clinician and embryologists. Last year, 2021, in Israel, Paul Berta has a retrospective cohort study on more than 4,000 patients with normal uterus with 3 consecutive aploid frozen transfer. He found that the rate of RIF is about less than 5%, not too much. There are many risk factors for RIF. First of all is the age of patient. With advanced maternal age can affect to embryo quality and endometrium receptivity. The second is the sperm DNA fragmentation. The stress of patient also affect on the result of IVF. The infection. There is a lot of articles talk about infection, especially in chronic endometritis. And other risk factor is immunology and endocrinology, etc. How about the intervention for RIF in the world? There are a lot of methods for treatment as lifestyle modification, treatment uterine disease, antibiotic for infection, embryo factor, antithrombotic agent, the immunotherapy, pre-implantation genetic screening, endometrial biopsy, and progesterone support. In our center, IVF Tâm Anh Hà Nội, Việt Nam, there are about 3,000 to 4,000 IVF cycles a year. Our definition of RIF is after 3 failed in vitro fertilization, embryo transfer. The rate of RIF in our center about 7%, a little higher than other center in Vietnam because we have to receive the severe patient from the other center. There are many methods for treatment RIF patient in our center. First of all, we do office hysteroscopy. We always ask patients to do office hysteroscopy if they have RIF. We always do at the day 2 to day 3 after stop bleeding. By hysteroscopy, we can verify the uterine cavity is normal or not. Here is some picture of RIF patient in our center. Here's adhesion, here's polyps and adhesion and endometritis. For this patient, small polyps and small adhesion, we remove polyps and cut adhesion by hysteroscopy. And for the endometritis, we can biopsy the endometrium for testing. The second is transfer blastocyst embryos. We know clearly about the quality of blastocyst embryo. We try to transfer blastocyst embryo for the patient with IF. We prefer use a frozen embryo transfer. With blastocyst embryo transfer, we have the rate successful in IF is about 40%. And the next is a pre-implantation genetic testing. We do all these things: PGT-A, PGT-M, PGT-SR. By PGT, we can choose high quality embryos without abnormal chromosome, so that the successful rate is higher. Endometrial scratching. There is controversy about endometrial scratching, but we also use endometrial scratching for IF patient. We only do the scratching for IF patient on the day 21 of previous cycle. It works for some patient because it's not expensive, and it works. The next is a platelet-rich plasma autologous. We use PRP for the patient with IF. We use PRP during the endometrial preparation. The success rate in IF of PRP autologous in our center is about 56%. And the last, I want to talk about ERA, EMA, and ALISTAT. With EMA, ERA, ALISTAT, we can know the exact day of implantation window and analyze the endometrial microbiome and diagnose chronic endometritis. Now let me talk about ERA, EMA, ALISTAT in our center. All of the patients in our center do EMA, ERA, ALISTAT. First of all, we have to eliminate all the abnormal uterine cavity of this patient. There are 20 patients in our center doing ERA, EMA, ALISTAT. 16 of them has a frozen embryo transfer. And I will talk about this patient. The mean age is 35 years old. 7 of them is primary infertility. The mean cycle of filler implantation is about more than 4 times. About ERA, we divide the ERA the result in 3 groups. Group 1 is about 118 hours to 122 hours. As a protocol we use for the all patient with frozen embryo transfer. There are 16 cases in this group. 12 has a frozen embryo transfer. 6 has pregnancy. Live birth 3, ongoing pregnancy 2, and 1 semicolon pregnancy. And the group 2 is long, 146 to 148 hours. We have 3 cases. All the cases have recommended to redo the biopsy, but the patient doesn't want to do. We do the frozen embryo transfer for them. 2 ongoing pregnancy and 1 filler. The last group is a short time, 110 hours. There is only 1 patient. Luckily, she has the baby now. EMA result. Normal result of EMA, there are 7 cases. 5 has been frozen embryo transfer, 2 live birth, 1 ongoing pregnancy, and 1 chemical pregnancy, 1 failure. This failure case is she has ERA test in long group 146 hours. The second group is microbiome with ultra-low biomass and my dysbiosis profile. There are 9 patients. They were prescribed vaginal probiotic contain lactobacillus treated. 9 of them has frozen embryo transfer, 2 live birth, 3 ongoing pregnancy, 4 failure. The abnormal endometrial microbiome, there are 4 patients. They was given metronidazole 500 milligram for every 12 hours for 7 days. 2 has frozen embryo transfer failure, and 2 last not has frozen embryo transfer yet. And about Alice's result, the 19 cases have a normal result. Only 1 patient has endometritis. She was given treatment by amoxicillin for 7 days. Overall, in the successful group, we have 9 patients with pregnancy. 5 patients have abnormal result of EMA test. There are 8 patients was transferred with blastocyst embryos. In the group unsuccessful, there are 7 patients. 2 of them was transferred with cleavage state embryo, and 5 with blastocyst transfer. 6 of 7 patients in the group normal 118 to 122 hours post-sexual, but all of them with abnormality in EMA test, they has treated, but they don't want to retest after treatment. The last the patient of this group is a woman 47 years old. In the group long of ERA 146 to 148 hours. She has only cleavage state embryo transfer. With EMA abnormality, she has treated, but she doesn't want to retest after treatment. The conclusion: recurrent implantation failure is a complex problem with wide variety of etiology. The recommendation for women with IIF vary depending on source of the problem. Personalized treatment is needed. Consider of blastocyst embryo transfer if possible. The test should be repeated in case of doubt or after treatment. Thank you for your attention.